We rely heavily on chronological age, the strict number of years a person has been alive. It is a necessary metric for legal frameworks, determining benchmarks like pension eligibility at 65. But as a clinical tool, the calendar is a remarkably poor predictor of actual physiological decline. This discrepancy requires a shift toward biological age, a personalized metric that evaluates the true physical condition and cellular health of an individual. At the cellular level, aging is driven by telomeres. These are protective caps at the ends of our DNA. With every cell division, these caps shorten. Eventually, they reach a critical threshold, triggering cellular senescence, where the cell stops dividing and tissue function deteriorates. This cellular degradation does not run on a strict clock. Lifestyle choices, oxidative stress, and environmental factors accelerate telomere shortening, driving up a patient's biological age entirely independent of their birth year. This chart visualizes the relationship between chronological age and physiological health. Early in life, the data points stay tightly clustered, but look at what happens past age 60. The trajectories diverge sharply. Two 75-year-olds can present with vastly different physical capabilities and disease burdens. Basing a treatment plan solely on a patient's birth year ignores these massive physical variances, leaving clinicians unequipped to manage complex geriatric physiology. Emerging technologies are starting to bridge this diagnostic gap. Researchers are currently utilizing AI analysis of retinal photography to scan the microvasculature of the eye and calculate a precise biological age metric. Aging involves the simultaneous accumulation of multiple chronic conditions. When an optometrist treats the eye without accounting for how a patient moves, the drugs they ingest, or their cognitive state, even a technically perfect prescription can become a physical liability for the patient. To manage this overlap in clinical practice, geriatric medicine relies on a specific organizational framework known as the 5 M's. These core pillars are mind, mobility, medications, multi-complexity, and matters most. Applying this framework in an optometric setting allows a clinician to take a chaotic list of age-related declines and structure them into an actionable, bespoke management plan. Let's apply this to a specific case. Our patient is a retired telecommunications engineer. He cycles frequently, does woodworking, and recently traveled to Morocco. His baseline optometric exam reveals normal intraocular pressures and healthy macula, but shows moderate cortical cataracts and a mild hyperopic prescription. Executing the first M, mind, requires evaluating cognitive status. We must differentiate between normal age-related memory changes, progressive neurodegenerative conditions like dementia, and delirium, a sudden onset of confusion and altered perception. Older patients carry a much higher risk for delirium. It is frequently induced by systemic external stressors, such as urinary tract infections, recent hospitalizations, or adverse medication interactions. Our direct optometric action here involves optimizing visual input to support his cognitive health. By ensuring his near vision correction precisely matches the working distances for his woodworking and reading, we help maintain the mental activity required to slow cognitive decline. There are strict boundaries to this intervention. If a general practitioner refers an older patient for a driving assessment, the optometrist's jurisdiction is exclusively visual function. Any clinical concern regarding the patient's cognitive capacity to navigate traffic must be reported back to the GP for a formal evaluation. This physical interaction leads to the second M, mobility. Physical stability in older adults relies intensely on accurate visual feedback. Ophthalmic interventions carry severe iatrogenic risks. Prescribing standard bifocals to an elderly patient can drastically distort their depth perception when looking downward, directly causing falls and severe physical trauma. Clinical protocols mandate that any older patient presenting with a history of unexplained falls or a sudden loss of confidence in walking unassisted must undergo visual field testing, even in the absence of obvious optic nerve pathology. When low vision actively impairs mobility, treatment extends beyond refraction. Optometrists must refer patients for home environment modifications, utilizing services to install high-contrast edges on steps and remove tripping hazards. In our case study, the moderate cortical cataracts are reducing his contrast sensitivity. Given that he is an active cyclist navigating public roads, this visual degradation poses a direct threat to his physical safety. For older adults, Prescribing for vision is functionally identical to prescribing for physical safety and mobility. The third M is medications. Geriatric care heavily involves polypharmacy, where patients manage long, overlapping lists of daily prescriptions. This chart illustrates the reality of altered pharmacology in older adults. As chronological age increases, hepatic and renal clearance rates decrease. Drugs stay in the system longer, raising their potency and significantly increasing the risk of toxicity. This environment routinely triggers a prescribing cascade. A patient experiences an adverse side effect from one medication, it is misdiagnosed as a new physical condition, and a second medication is prescribed, creating a hazardous spiral of pharmaceutical load. Returning to our patient, he is actively taking atenolol and rosuvastatin. The intersection of these cardiovascular drugs with any new ophthalmic treatment requires precise verification to prevent adverse reactions. Often, the correct clinical path is deprescribing. If a 90-year-old patient presents with early-stage glaucoma, the clinician must weigh the daily side effects of ocular hypotensive drops against the patient's overall life expectancy to determine if the intervention actually provides a net benefit. Every new ophthalmic prescription acts as a systemic drug, entering an already fragile biological ecosystem. The fourth M is multi-complexity. This requires clinicians to adopt a biopsychosocial perspective of the patient's health. Normal physiological aging, like the onset of presbyopia, is not a disease. But when these normal changes operate concurrently with active chronic illnesses, they compound to severely limit the patient's daily function. This necessitates bespoke management plans strictly tailored to the patient's living arrangements. Prescribing an eye drop that requires midnight dosing is a failure in care if the patient only receives assistance from a daytime caregiver. Managing this complexity relies on aggressive interdisciplinary communication. Securing permission to send routine clinical reports to the patient's primary GP ensures the entire healthcare network operates on the same data. A clinically perfect prescription is effectively useless if it is incompatible with the patient's actual living conditions and social support structure. All of this diagnostic data funnels directly into the final M, matters most. We have generated a highly interconnected web of systemic realities, linking his cardiac medications, the surgical parameters of his cataracts, his mobility needs for cycling, and his cognitive baseline. To finalize a treatment plan, we consolidate this data around the patient's ultimate goal. For this specific engineer, the clinical priority is maintaining the physical independence required to ride his bicycle and travel internationally with his wife. This dynamic culminates in the highest stakes scenario in geriatric optometry, assessing visual fitness for driving cessation. Revoking a driver's license triggers severe cascading consequences. It directly correlates with a sudden loss of independence, deep social isolation, and the rapid onset of clinical depression. The results of a visual acuity report or a visual field test directly determine whether an older patient can remain mobile or is transitioned into a state of forced dependency. Treating a geriatric eye in isolation ignores the biological reality of the patient attached to it. The 5 M's operate as a vital translation tool, allowing clinicians to convert systemic medical complexity into precise, safe optometric care. Mastering this framework integrates optometric care into the broader multidisciplinary effort to manage geriatric health.